You are welcome to my channel. Thanks for visiting. Remembering to subscribe, listening to all my presentations, and sharing them. If the purpose of clicking on this is to have details, all the pieces of information on migraine and a device that could help with the treatment and even prevention of migraine known as CEFALY, if that is your goal, you are in the right place. Because today I will take you through everything you need to know as far as migraine is concerned, the different types of migraine, the signs, the symptoms, preventive measures, all different medications you can use, and how CEFALY will be helpful in the face of migraine attacks and prevention. With that, let's go. Now, the migraine. There is primary headache. Now, you've heard about tension type headache, cluster headache, and so on. And then there's secondary headache that is caused by something, and we need to know what is responsible for it. Migraine is a primary headache, okay? And there could be abdominal migraine, hemiplegic migraine, bacillar type migraine, retinal migraine, vestibular migraine, menstrual-related migraine. I will address all these right here today. So migraine. Now, the focus is on migraine. Later on, we will hit the stage for CEFALY. Okay, let's go. Before we can get a full understanding of migraine, we need to define certain terms. The migraine headache. The migraine headache is a very common neurological problem. It is going to cause a lot of trouble for the affected people, giving them strong, throbbing, pulsating unilateral headache, but it might be bilateral. I'll not waste your time here saying too much because we'll go over risk factors, signs and symptoms, treatment and prevention in a bit. Now, aura. Some call it aura, some call it aura, depending if you're in North America or Mexico or in UK. That is a distinct sensation perceived just seconds before or during migraine attack. It could be verbal. In other words, it will be known as dysphasic aura. It could be visual loss, and it could affect your vision in different forms, giving you different shapes, bright spots, flashes of light, and there could be hemiparesis and so on. Then there is an entity known as classic migraine or migraine with aura. That's just it. When the migraine is with aura, it's known as classic migraine. Some don't use that term anymore, classic or non-classic. Okay? It could be migraine without aura. That is a common migraine. It's an old term that people may not use anymore. Okay. Then we have typical aura without headache. In that case, that is known as a silent migraine. Okay. It is also known as asephagic migraine. Other symptoms and complications associated with headache that we'll go through here could be present here, but there'll be no headache. So the aura will be there. They can come down with possible complications associated with migraine headache. They can have all other signs and symptoms, but there's no headache. So it is a silent migraine. Persistent aura without infarction. From this simple English word, persistent means is there continuously, but when we're using that with aura without infarction, what we meant is simple, and that is there is aura that is lasting for months or years, but without infarction means without stroke. And of course, migraine agony. This is a very serious, painful, throbbing, and pulsating headache. Triggers have been disproportionately responded to by the brain. Then, there's massive brain electrical activity leading to increase in changes in brain blood flow, and the changes will affect the nerves. Hence, the individual will have very serious pain. Status migrainosus. This is a relentless migraine attack. Status, you remember? Epilepsy, asthma, and so on, right? Something that is just strong and not waning down. Exactly. That could happen also in migraine, okay? And it could last more than 72 hours. It's likely going to be associated with repeated vomiting. And when somebody is vomiting repeatedly, electrolyte imbalance, fluid imbalance, then there's dehydration, right? Okay, and when there is relentless, repeated, attack like that, you'll be, finding it difficult to sleep. So there could be insomnia. We also have migrainous infarction or migrainous stroke. This is likely going to happen more in younger women. It is associated with narrow blood vessels and can occur suddenly. It might be with aura, like flashes of lights, blind spots, tingling in the arms and face. It is worse or more likely if the woman or the women is or are smoking cigarettes and are also taking combined oral contraceptives at the same time. Then we have an entity known as migraine trigger seizures. This is similar to epilepsy, right? And it's likely going to be in those with aura, or it's going to occur immediately after migraine with aura has occurred, that is after classic migraine. So these are terms that I've taken time to define right now. They'll be useful as we progress. Now, the epidemiology of migraine. It's mostly going to start at adolescency, but don't take it hook, line, and sinker. It could be at any age, and it's going to peak at 30. The abdominal migraine is going to take a different course because it's going to occur earlier than adolescency. So it could be, some literature will put it from age 3, some will say age 7. Whether 3 or 7, I've helped you out, 3 or 7 to 10 years of age. So the 3rd birthday up to the 7th birthday, that could be the onset of abdominal migraine, and up to age 10. But by the time we start talking in details as per abdominal migraine, which I will do right here today, we'll discover it could also be present even in a woman of childbearing age. So in adulthood, it's possible, yeah. It progresses to adulthood, that is migraine generally, but with decreasing frequency and severity. Do you want me to explain this? Okay, I'll do. Yeah, migraine is likely going to be among high school kids and then the college, people, the university people, just, at 30, that age from 15 to 30, thereabout, where you'll be by then. But it's not going to stop suddenly. It's likely going to progress till the person becomes an adult. One thing will be different though. At adulthood, the rate at which the attack will come and how bad it's going to be will be going down as you grow older. Male to female ratio is 1 to 3 respectively, meaning more females will be affected. It is likely going to worsen around menstruation. Well, it is obvious, more female will suffer from that, so it's going to be worse around menstruation. There is menstrual migraine also. It improves after menopause, expectedly so. Now, the clinical features, meaning the signs and symptoms of migraine. Now, we want to go into what you are going to tell the physician or what the physicians and nurses will pick on their own physical examinations. Then, migraine clinical features. There are 4 stages here when it comes to migraine. The prodrome is going to occur in about 50 to 70% of affected individuals. And what am I talking about when it's going to prodrome? This is going to start at 1 to 2 days before the attack. That is what it's saying, pro. Okay, there may be changes in the mood. Some will become euphoric and some will become depressed, but they will know something is changing in them. Then frequent yawning, you tired, you hungry, and so on. But if you are tired with migraine, you can note that from today. Food cravings, a particular food will be of interest to them. They can become constipated and they may be retaining fluid. And some will have urinary frequency and there may be neck stiffness. All these will be at prodrome in 1 to 2 days before the attack. If you have that, then you have the warning already. Reduce the stress and whatever we can do, we'll get to that in a bit. Then the second stage is aura. This is a distinct sensation perceived just seconds before or even during the migraine attack. Examples abound, but they are most visual in origin, but could be sensory, motor, or verbal. For example, the verbal could be there will be difficulty speaking. Some term this as dysphasic aura. There may be visual loss. There may be vision of shapes, bright spots, and flashes of light. One side of the body, affecting the face and the arm up to the tongue, could become weak and numb. There may be pains and needle sensations in the arm and leg, and so on. It can occur before, like I said earlier, could be during, or might even be after an attack of the migraine. They are reversible. There's one good thing about that. And it starts gradually and increases the same way. It means it increases gradually. It can take minutes to an hour. For example, aura could last between 5 minutes to 60 minutes. And of course, it's from the central nervous system. It can have aura without the headache. I've explained that just a while ago. You can pause and rewind under the definitions. Aura without headache. Now, the stage of the migraine attack itself. This can last for a few hours, like 3 hours to 72 hours, I wrote 4 or days here, because sometimes it might be greater than that, like status migrainosus, where there will be relentless migraine attack that could last for more than 72 hours. So, it's unpredictable how long it may take. It's mostly unilateral, but could be bilateral, and there may be associated nausea and vomiting. The vomiting could even be so severe that the individual will become dehydrated. Then the headache could be pulsating or throbbing. Throbbing here means it's causing pain in a regular beat. It's going to be strong, regular pounding pulsation. And you have an example in the body, of course. Feel your heartbeat. That is the way it is for people with migraine. Now, you should have some level of empathy for them. It's serious. Now, pounding like heartbeats. Now, another example is back pain and a pulsating abdominal aneurysm. That's another example of throbbing, that could be defined. There may be photophobia or phonophobia. That is, they will hate light in photophobia, They will hate sound in phonophobia. That is why we'll keep them in a dark, quiet room. Also, osmophobia, there'll be aversion to odors, and they will be highly sensitive to touch, and even combing their hair and so on, leading to allodynia, that is a sense of pain in a similar that ordinarily is not painful. So the migraine last stage will be post-drum, that is after post, right? So the individual will feel tired after the attack and become confused. Some will feel elated, and this can last for a whole day. Now, other real or fixed clinical features, we've just gone through these stages. The migraine headache, often unilateral, like I've said earlier, but not always. It could be bilateral sometimes. Throbbing, I've explained what that is all about, very serious. Or pulsator, associated with nausea and vomiting. Photophobia, light, they don't want light around them. Phonophobia, they don't want sound. This is not when you turn your, surround over to the peak of the volume. No. So we look for dark and quiet room for them. Also, they have aversion for odors. Still on clinical features or signs and symptoms, they will have allodynia. That is a kind of situation where you have extreme sensitivity to touch and to what is not even painful that will become painful for the affected person. So they will have pain when you touch their scalp in any shape or form, including shaving or even combing. Then resting on the affected side on the ground or any object will give them pain. There may be bacillar type migraine. If that is the case, the affected individual will have vertigo. They're feeling dizzy, ground turning around them. Okay. Ataxia and dysarthria. They will not be able to speak correctly for that period. Visual aura would be timed to be positive when it is zigzag lines that they are seeing along with flickering lines, but it is negative when there is scotoma. Here, scotoma means a partial loss of vision. If that is the case, that is negative. The sensory aura is timed to be positive when it is pains and needle sensation, but it is timed to be negative when it is numbness. Still on signs and symptoms of migraine, could be hemiplegic migraine. Here, RIA will be in the form of motor weakness with visual field defect, scintillating scotoma, numbness, paresthesia, aphasia, fever, lethargy, seizures, and coma. On signs and symptoms, again, it might be retinal migraine. In this case, there will be transient association with blindness, and there might be vestibular migraine that will present with vertigo. So when anyone is having vertigo, it is fair to have differential diagnosis as migraine. Might be menstrual migraine. This will occur during menstrual periods. Then abdominal migraine. Although this will form a separate topic right here today, so I will not waste your time here. But we mostly find this in children. However, it's not limited to childhood age. Now, risk factors or triggers. Let me give a general note here that risk factors are those factors that can increase the chances of having a disease. Not only in migraine, anywhere. Once you say risk factors, that is what it's all about. Whilst triggers are specific events or items that can set off or spark of a process that will lead to signs and symptoms in an individual. So that's why I matched the two. Okay, the risk factors, are those stuff that can increase the chances of having a particular disease, while triggers will be a specific agent or event that can set off or spark up a process that will lead to signs and symptoms. Nothing is fixed as per triggers. How do I mean? Triggers in one person may not be the trigger in the other. So I've decided to give this explanation so that by the time we continue on the journey of this trigger and the risk factors, you will not be sending too many questions to me. Okay? It might not be a trigger in you, but it might be in someone else. But it means as a record that it has been a trigger in someone with migraine headache in the past. Okay? So nothing is fixed here. Other triggers may have to be present before some other triggers like food-related ones will actually have effect. Is that making any sense? Okay. Well, let me say some risk factors will have to be on ground before certain triggers can actually tilt the individual to migraine attack. It is almost individual basis, meaning whatever can trigger migraine in A may not trigger migraine in B, and what can trigger migraine in B may not trigger migraine in A. Let's get that clear, please. So the list here are just the common ones that would have been reported all over the world and put in literature worldwide. So nothing is local, nothing is peculiar to any region when it comes to triggers of migraine. Okay, and it's not going to affect all sufferers of migraine at the same rate. No. It is fair to say that you can't avoid all the listed triggers here because I've taken the time to go through what people had complained about as triggers, what has been written in so many literatures, and I wanted to get everything here. That's why I put it A to Z. So it might not be fun in you. Some will be fun in you. Some are not there. Some may be in your patient, may not be there. What is important as we go on now is study your own trigger or triggers by keeping a diary, please. Now, the risk factors. Hereditary. This is non-modifiable, okay? Majority of people with migraine will have positive family history. As a matter of fact, we'll start from there. You need to find out from your parents about the history of migraine in your family. And it's going to be more in females than males, meaning males are not immune to migraine. They can also have it, but more females will have migraine. Now, environmental factors. Now, we've skipped the hereditary, the non-modifiable. Now, the modifiable factors. You have to watch out for trigger or triggers by keeping the diary of what have you done close to the time you've been having the attack, and that is, appearing to be consistent. Then, start avoiding them. And that could include, but not limited to, stress, pregnancy, insomnia, or you just have sleep changes. For example, you are a nurse, you are a doctor, you are a police officer, you are a security agent, you do shift work. Today you work night, tomorrow you work day, the other time you work morning, just back and forth, your sleeping cycle is not fixed. That may be a trigger. Depression, you are depressed, increased weight, changes in weather, particularly if you are in a temperate country, you're in North America, you are in Europe, where we have winter, we have summer, we have spring, we have everything changing back and forth. it may trigger your migraine. Or menstruation. Needless to say, we repeated it here. You are a woman, childbearing age, still menstruating, and you have migraine, it might come up more at that time. You can conveniently say that migraine problem is both genetic and environmental, meaning there's underlying genetic constitution, but it will come up, you will reach the attack stage when triggers are there to set it off. Certain medications and chemicals can act as triggers. So again, let me reiterate here. Don't bombard me with questions that I've been using perfume and I have a headache and I'm not having migraine headache attack. Fine, I said it earlier. What would trigger the migraine attack in some people may not trigger it in you. But if you have never known before that strong perfumes can trigger migraine headache, now you know. You get it for today. Okay. Also, combined oral contraceptives. Young women, childbearing age. Migraine in your family, or you've been diagnosed with migraine, and you're on this. Oh, that might be the reason why you have been visiting your physician consistently. Or you think your preventive medications against migraine are not working. It's not that they're not working. This is it, combined oral contraceptives. Hormone replacement therapy, nitroglycerin, opioid, selective serotonin reuptake inhibitors, proton pump inhibitors, even as small as decongestants. Why did I say as small as decongestants? Because when we look at all this, we think they are big medications, right? In fact, we use some of them even for prevention. We'll go into that later on. And why could something you use for prevention turn out to be what will trigger your attack? We'll get into that all here. Now, decongestants is only something small. You just get to the store, over the counter, you just grab it, and you don't know that could trigger your migraine. It could. Reburn from analgesics like non-steroidal anti-inflammatory drugs, acetaminophen, and so on. Maybe. No, so this is tricky to many people because there's headache and you are using the correct medications to suppress the headache, but you are going to use it and get to another level that even the analgesics you are using will give you a rebound later on, will give you headache back. We'll see that as we proceed. Now, certain foods and lifestyle could serve as triggers. If you take too much caffeine, let me explain here because my friends want to fight me now because they want to have that coffee and have it 3 times a day and have big jug and go around with it, walk on the street, walk their dogs with a jug of coffee in their hands. No, that's fine. But too much caffeine can trigger your migraine headache. Just know that. Okay? When you take caffeine moderately or low level, can even be advantageous. Yes, could be. Then alcohol. You won't fight me now. So what is it talking about? The choice to take alcohol is your choice, okay? But when you have migraine headache and you are taking wine, then don't complain that the medications you are taking are not working or the attack has not went down. No, that's it. Cigarettes smoke like in secondhand smoke. Why did I pause? There's a separate presentation by me here already published, that we should put cigarette smoking under control. The smoke, you are not the one smoking, but you have migraine, you've been diagnosed with it, it's running in your family, and you are always sitting by your spouse, your friend who smokes. Man, that's why you are having repeated attacks. You may not know it. And you just keep diary after today, okay? Cheese, we'll go into that later on. Too salty foods, some processed foods, monosodium glutamate. You know that for seasoning. Certain places could serve as triggers. Somebody is saying, oh, I'm curious. Where can I go? Where can I not go? Oh, let's see. If you are in a place with too bright lights, the room is too bright, with so bright light, and you are a migraine headache sufferer, that could trigger your attack. Okay, or if your attack is already giving you signs, or you are already in a prodrome, then you come down. Flashing lights. There are some stuff I've seen where people will sit down and in some concert, the light will just be flashing. If you have migraine or seizures, you might have attack. Loud sound. No, over. Turn it to the highest, volume. And nobody could even talk to somebody because the sound has, oh, what? Your attack can come. Strong odor. If you don't agree that strong perfume can trigger your headache, how about strong odor? It's the same. Other certain triggers could be excitement. You are too happy, but how are you going to tell somebody not to be happy or whatever? But you understand what over excitement could be? Emotional changes, motion sickness, exhaustion. That's why when you have migraine, you just do everything moderately. Just try to. When you overwork yourself, you're in trouble. When you can't sleep, you're in trouble. Swallowing excessive air. Well, some can do that intentionally, but if you do that intentionally and you are a migraine sufferer, then you are going to tilt yourself into an attack. Nitrates in certain processed foods like processed meat, chocolate, and other processed foods that will have nitrates in them, then that could trigger your migraine headache attack. Caffeine. I've decided to come back to caffeine fully because I know a lot of people will bombard me with comments after. Seldom use is not a problem. Okay? Actually, that could be positive. Why? It can actually help. If you have a migraine headache and you drink coffee occasionally, that could help. Heavy consumption is the problem because heavy consumption with withdrawal effects will then trigger the headache. If you are on low coffee level or moderate quantity, well, that can actually help you to bring down the severity of the migraine attack. Salty foods may increase blood pressure, and when there is very high blood pressure, that may lead to headache. If you haven't listened to my presentation on hypertension A to Z, please kindly do. This has been explained there. Then ice cream headache. You are used to that, it's not a new term. Or you are drinking chilled water and you are drinking that rapidly. Or you are taking frozen foods, you don't have time to microwave and you have headache before, migraine headache. All this could trigger your new attack. Aged cheese containing tyramine. Yes, so when somebody is saying cheese can trigger your headache, it's not all of them. Those containing tyramine will trigger it. Foods having nitrates, I've said this before. So why am I bringing it up again? Because you can overlook it. You can just overlook it. And it's important. I want you to feel okay. I want you to feel well. So, and don't fight me. So does it mean I will not be eating hot dogs again and my sausages? No problem. If it's not, a factor that triggers headache in you, that's fine. I said it's not going to happen in everybody, but there are some human beings. Take it from me, please. There are some human beings that hot dogs, sausages, preserved with nitrates would trigger their own migraine attacks. Yes. So the other time I mentioned monosodium glutamate, but let me specifically say that a research was done by American Migraine Foundation, and they found monosodium glutamate to be a trigger in 10 to 15% of migraine headache sufferers. So if you say, I've been taking monosodium glutamate, I'm seasoning my food, my meat with it, and I've never had a attack, do I have migraine? You belong to 85 to 90% of the sufferers that would not have it. That is it. How about chocolate? Some will say, I've been taking my chocolate, I have migraine, my sister had it, and none of us is having an attack. You are fine. But American Migraine Foundation found chocolate to be a trigger in 22%. So you are one of those 78%. So don't write anything off here, please. Alcohol, the red wine, I've explained that. Artificial sweeteners like aspartame can be a trigger. Now, prevention. Prevention, they say, is cheaper than cure. That is, if the situation is even curable at all. Now, when it comes to migraine headache attack, it is going to be better that we lay emphasis on prevention because the sufferers would not find it funny in the face of attack. Okay, let's go. Migraine headache prevention. We're going to start the journey by addressing ourselves. We should adjust our own lifestyle. Have a good sleep, have routine meals and schedules, and have regular exercise. Do you think that all this could help? Absolutely. The other time I said keep the diary of the migraine headache, and you yourself can help yourself to trace what could have triggered it. And once you know the triggers, the next thing is to avoid them like plague. That would be my own advice. But you may choose to cope with them. Well, because it depends on what the trigger or triggers could be. Now, there is the possibility of transcutaneous supraorbitudinal stimulation. CEFALY will be discussed further. You can have acupuncture or Botox injections. You may go for medication like pizotifin, that is endomigraine. Riboflavin may be helpful. Simvastatin with vitamin D might help. Naproxen is non-steroidal anti-inflammatory drug. Melatonin at low dose of 3 mg per hour might be helpful. Anti-epileptic drugs could also play the good role here, like valproate, but you don't give valproate in pregnant women or women of childbearing age. Why that? Teratogenicity. In fact, it will be advisable that you have human chronic gonadotropin acid and make sure there's no pregnancy while on valproate. Well, a woman of childbearing age, why would you go for valproate for prevention in them? No, to avoid all these, complications, teratogenicity, just keep evaporating them, use valproate in men and some other people. Then you can have topiramate. Topiramate will be helpful in the face of obesity and an individual with epilepsy now having migraine because topiramate can decrease, weight. It's also an anti-epileptic drug. But you have to go through the possible adverse effects or side effects of topiramate with affected individuals. Flunarizine is a calcium channel blocker. We know where we can all use calcium channel blocker, and including verapamil. There's a full presentation on verapamil already on my channel, published. You can check it out. We won't use this in anyone with heart failure. We know that, right? Amitriptyline or nortriptyline is a tricyclic antidepressant. Will be helpful in individuals with insomnia. Now, having migraine headache, the insomnia can trigger the migraine can lead to insomnia. Also, with anyone with migraine attack having pain in some other parts of the body or is anxious, you can go for tricyclic antidepressant. But be careful. The horrible side effects on the heart should give us concern, and of course, the anticholinergic effects. Clozapine is also a tricyclic antidepressant for insomnia, depression, anxiety, and even pruritus. So, somebody is having migraine headache, having pruritus that will not respond to antihistamine and so, then you want to give clozapine. That would be good, but let him or her know the other terrible side effects of tricyclic antidepressants generally. We can use beta blockers, but it depends on the type of beta blockers you want to take and who is about to take it. Beta blockers in someone with asthmatic attack should not take non-selective, like propranolol. Should take hard selective, beta 1 selective, because when you block beta 2, then the bronchi will be in trouble. So we'll be careful the type of beta blockers in particular type of patient. Now, somebody is having migraine and having COPD at the same time, or is having migraine and having asthma at the same time, propranolol would not be welcome here. Lisinopril canacertain. Somebody is having migraine and is having diabetes mellitus, then lisinopril canacertain will be good. ACE inhibitors, angiotensin receptor blocker. If there's reaction to ACE inhibitors like angioedema, then you go for angiotensin receptor blocker. This will be helpful in individuals with chronic renal disease and diabetes mellitus because of cardiorenal protective properties that they possess. Gabapentin and venlafaxine, all this could be helpful, but then we'll go over the side effects as well. Now, there is CGRP antagonist, that is calcitonin gene-related peptide antagonist. They are injectable monoclonal antibodies, and examples are right here, and even more. They are newer medications, already approved in US by FDA from 2019 and 2020. So they are new and already approved for both prevention and treatment of migraine headache. The third-line agents are feverfil, tizanidine, memantine, pregabalin, cryopeptidine, and zonisamide. So this will be when you have tried all those previous ones and you're not winning, or certain situations will not let you use that, then you can try some of these, but with full interaction with your pharmacist and your neurologist. Now, the diagnosis of migraine headache. How can we make accurate diagnosis of the migraine? Okay, let's go. Atypical migraine is also known as migraine without aura, and in the olden days they called it common migraine. That'll be lasting for 4 to 72 hours. All you need to do here is, since there's no aura, then you must rule out other causes of headache. If there's none, no other cause or causes of headache, you may go ahead. And this individual is presenting with photophobia. They don't want to see light right now. They don't want to hear loud sound, phonophobia. There's nausea, there's vomiting, it's unilateral, but it may not be all the time. It's pulsating or throbbing. Decreasing routine life activities is already affecting this person. Then you can make the diagnosis of atypical or migraine without aura, or common migraine as known in those days. Now, typical or classic or migraine with aura will present in form of aura that could be visual, sensory, speech-related, language, motor, retina, or even affecting the brainstem. At least, we are going to pick one aura over 5 minutes. 2 or more symptoms, one after the other, will be occurring, and symptoms may be lasting for 5 to 60 minutes. I mean, symptoms of aura affecting others, okay, followed by the headache. So the aura will be affecting all this over 5 minutes, up to 60 minutes, then there'll be headache. Now, still on diagnosis, we may go beyond typical and atypical sometimes when we are faced with certain situations. Like this person is having HIV and is having AIDS. You've done HIV screening to know, and that may be secondary headache. But remember, when there's classical presentation, then there's something else. This is the first headache ever in this man or woman, and this man or woman is greater than 50 years old. Then, something may be happening in the brain. Let's have CT or MRI done. You are suspecting cancer. Then let's screen, right now. Or there's diagnosis of cancer already. Then let's have CT, MRI, or PET done. See whether we're battling with metastasis or the cancer is even within the brain itself. Is this meningitis? Or you are just suspecting? If that's the case, let's have lumbar puncture done. You might have CT done before your lumbar puncture, depending on the age and the presentation, so that you will not be blamed after. If this headache is occurring at the same unilateral side all the time, then you need to know what is happening in that brain. There's increase in frequency of migraine attack, and the severity is also getting worse with time. Then you have to do all. How do I mean? You will do CT if it's available. If it's not, you do MRI quickly. With that one, you have to do that and have your culture, please. So you want to know exactly what is happening. Brain assets, something is accumulating in the brain, tumor is growing, something is causing increase in the cranial pressure there. You want to know. If this is the first headache and it's like migraine headache, but for you to make definitive diagnosis, besides the family history, the risk factors and triggers, it will be better you have all this done so that you'll be sure you are dealing with primary headache, that is migraine headache. If this patient is telling us, this is the worst headache of my life, is thunderclapping and so on and so forth, oh wow, so subarachnoid hemorrhage is suspected. CT quickly. If there is accident neurological impairment, CT or MRI. If you have been doing everything, you've made your diagnosis and you are giving everything, but the patient is not responding to the treatment, then have CT or MRI and culture done to be sure it is still primary headache, not secondary headache. Now, it may not be migraine. If it is not migraine, what could it be? So, we are getting to this tiny house now to see the possible differential diagnosis of migraine headache. So the first thing to do when we think we're not winning is to review the history. We've ruled out HIV/AIDS, the first headache in someone greater than 50 years old. We've ruled out all possible causes, like brain tumor, accumulation in the brain, hematoma, abscess, and so on. We rule out cancer, we rule out meningitis, same lateral side all the time, increasing in frequency and severity, first aid, what's the headache of my life, neurological impairment, not responding to treatment. When we find all this, or one of these, we cannot even find all this in one person. Wow, why would that be? Life will not be fair to that individual. When we find one of these, and we've been thinking before, this is migraine headache, then we should pause a bit. We might be dealing with something else. Okay, the headache might be migraine with or without aura. It might be cluster headache, another primary headache, might be tension type headache, and might be trigeminal autonomic cephalgia, that is cluster plus migraine. Might be chronically daily headache, as either will cough or exercise, or you understand this, I'm not going to say it. It might be transient ischemic attack or increased intracranial pressure. It may be meningitis, might be brain tumor, might be subarachnoid hemorrhage, might be intracranial hematoma with or without stroke, otherwise known as cerebrovascular accident. And might be secondary hemorrhage from what? From all this and even more. We have to look for the cause. Now, we've gone through the risk factors, the triggers, the preventive measures, the proper diagnosis has been made. We've ruled out all other differential diagnoses. We are sure this is migraine headache, primary headache. Then, how do we treat? The patient must get out of the problem. In the acute phase, we end up in emergency room. There, sumatriptan 6 mg could be given subcutaneously, and we can repeat that in 2 hours. Vomiting can be handled with metoclopramide 10 mg intravenously. You might give your IV fluid if the individual is already dehydrated from massive vomiting. Dihydroergotamine 1 mg intravenously. Be careful with the blood pressure. Ketorolac 30 mg intravenously or 60 mg intramuscularly can all be given in the emergency room. But emergency room physician make that determination. Now, if it is not that severe, it is mild to moderate migraine, we are not heading to emergency room, then we can pick analgesics like non-steroidal anti-inflammatory drugs, aspirin, naproxen, ibuprofen, diclofenac, and even acetaminophen, your Tylenol, and so on. For vomiting, can still give metoclopramide intravenously. Haloperidol can be helpful. Promazine could be helpful intramuscularly, but watch out for the blood pressure, can shut it down. Propylperazine intramuscularly or intravenously. You may give Benadryl to prevent extrapyramidal side effects. Can also go for other anticholinergics, depending on what is obtainable in your jurisdiction. I have a separate presentation on antiemetics, already published, right here. Then when it comes to the triptans, we have sumatriptan, sumatriptan, rizatriptan, alitriptan, and amitriptan. You can use ergots, but let's take note of this. Dihydroergotamine is preferred here in migraine attack. There's also another one, ergotamine tartrate, but we are not going to use that here. And why that? It can increase nausea and vomiting and even rebound headache. And when you use it on a long-term basis, that will give you valvular heart disease. So I'm not campaigning against a glutamate titrate. I'm not campaigning for dihydroergotamine, but I'm just releasing the fact to help the patient. Dexamethasone may be helpful intravenously or intramuscularly. CGRP, we came across it earlier. That is calcitonin gene-related peptide antagonist. They are injectable monoclonal antibodies, and examples are here. There are newer medications, but already approved by FDA in 2019 and 2020 for both prevention and treatment of migraine. You can have lasmiditan. The brand name is Revo. That is 5-HTIF receptor agonist for acute migraine treatment. You use only one tablet once in 24 hours for migraine with or without aura, and is useful only in adults, not in children. You may embark on surgery like vagal stimulation or supraorbital nerve stimulation will gain more NIBI. The right path to successful handling of migraine headache will include thorough history and physical examination, including the risk factors and triggers, accurate diagnosis when you've gone through the symptoms, the risk factors, the triggers, then you've made your appropriate and accurate diagnosis, we're back on appropriate treatment. If we follow this course, we'll have a good outcome. Now, complications of migraine headache. Somebody will say, why wasting our time on going through complications? It's not what we can just overlook. As physicians to patients that are suffering, and as family members to our family members that are migraine headache sufferers, we should know they're passing through a lot. The empathy should be there. Now, let's go through the complications. There may be depression, anxiety. Now, someone is having this horrible headache and is occurring, monthly, 2 months apart, 3 months apart, every year. It may become dehydrated from massive vomiting. And when they are dehydrated, there may be hypotension leading to hypovolemic shock. Maybe insomnia. Somebody having headache will not be able to sleep. Insomnia can lead to headache. Headache can lead to insomnia. Maybe vertigo. We've gone through how that could be the other time, bacillary type, and give that. This page is not directly from the headache, but indirectly from the medications that will be used. We've talked about using amitriptyline or triptyline the other time, and even Benadryl. All these are anticholinergic agents. They can give blood vision, tachycardia, urinary retention, dry mouth, even constipation. There may be hepatotoxicity from sodium valproate and some other medications. Valproic acid can give hepatotoxicity. So I'm not sure that inflammatory drugs can lead to myocardial infarction and even heart failure from retention, acute kidney injury, peptic ulcer disease. When you take non-steroidal anti-inflammatory drugs on empty stomach, the gastric lining will suffer. Maybe abdominal pain. We have to be sure it's not abdominal migraine, although we'll delve deeper into that in a bit. Maybe electrolyte imbalance. Migraine triggers seizures, so they can come down with seizures triggered by the migraine. Serotonin syndrome from medications they are taking. the burn headaches or analgesic-induced headache. And maybe loss of productivity. Yes, you hire a young lady to be the secretary at a company, but all the time she's complaining of headache. Not that she's pretending, it is true. Then she won't be able to work all the hours, and then shift work will be affected. A nurse that is having migraine will definitely complain at work and plead that she should keep a particular shift. Change of job, of course. Inability to enjoy life to the fullness, yeah. No, just can't do everything that your friends and family members are doing because you have to go there with certain medications and then you can't be in a particular room. Some people will attend concert and loud music, flickering lights and nothing's happening, but not you. Mhm. It can affect the lifestyle generally, and call for changes. Even prevention will start from lifestyle changes, generally. Now, CEFALY. CEFALY is a device. It's not a medication. It's not a disease. It is a device. You can get it over the counter in Canada or through prescription in the United States. It's all over so many countries across the globe, in Europe, in Australia, in many parts of the world. It's helpful in the face of episodic migraine and trigeminal neuralgia. It is meant for acute treatment and also for prevention of migraine headache. It can raise the headache trigger threshold. Let me explain. Headache trigger threshold, meaning the level that the trigger will reach before certain headache in motion is going to be higher when you use the CEFALY. Is leading to less frequent migraines in the users and reduces the level and the rate of medications needed for migraine treatment. And of course, when the rate of using the medications has dropped, the cost will drop, the side effects will drop. Before going further on CEFALY, let me quickly claim it and clear it here that I'm not an agent of the company manufacturing CEFALY. No, I'm not. But what I've done and I'm still doing and I'm continuing to do is to bring facts to you as someone having migraine headache in your family, or you yourself, you're a sufferer, or you are a healthcare provider, a nurse, a physician, handling migraine headache. That's a device known as CEFALY that could be helpful. So it's meant for external trigeminal nerve stimulation that is capable of reducing the frequency and intensity of the migraine attacks. It's capable of reducing headache by about 46%. But I have broadened and enlarged this right here that you use this in 18 years and older, please, meaning in adult only. It is still new to so many parts of the world, but it's no longer new to some. It's been around for some years now in North America, Europe, Australia, and some parts of Asia. Some claim that it is well tolerated, but others fight the exact opposite, meaning it is not well tolerated. Even when you are given one of the least medications in the world, we are not going to react the same way, right? It will surely lead to a drop in those who can tolerate it. That is, those who can tolerate and they are using it, it will lead to a drop in migraine attacks and are using it with help of their physicians. So let your physicians know, they know, So may give it a no. Try it. I don't know. CEFALY is having more than 300,000 devices in circulation since 2008. Okay. FDA has cleared this device for migraine treatment, meaning they have approved it for migraine treatment. It raises the trigger's threshold and decreases attacks. Let me explain this. When the threshold is raised, it means the stimulus must be stronger enough, must be high enough before it can set off an attack. Okay, so many triggers will not reach that threshold, so no attack again. It is drug-free. There's no drug inside, and there's no surgery required. The mechanism of action or other instructions will not be presented here. I don't have any deal with the company that manufactures CEFALY. I have just come here to present the facts and take it like that. CEFALY is helpful. So discuss with your physician. Abdominal migraine. Abdominal migraine. We will spend the last section of this presentation on abdominal migraine. Without further ado, I will lead you there right now. Epidemiologically, abdominal migraine is uncommon. Glad to hear that, right? But it could be very difficult to diagnose, and it could actually be wrongly diagnosed. It is mostly found in 1 to 4% of children, but it's not limited to childhood. It is mostly going to occur in children between ages 3 to 10. Some literature will put it as 3 to 10, some will put it 7 to 10. Either way. After the third birthday, there may be a problem. Symptoms will be decreasing in frequency and severity as those children are growing older. So the older they become, the less the frequency and severity of abdominal migraine attacks. Still on epidemiology of abdominal migraine, 90% will have positive family history of abdominal or classical migraine. More in girls or females than boys or males, just as migraine generally is more in females compared to males at ratio 3 to 1 respectively. The risk factors are similar here, just like the way it is to the classical migraine. So you can just pause and rewind and go through the risk factors or triggers together. Usually outgrown, but 70% will later develop into migraine headache or abdominal pain in adulthood. What are the clinical features of abdominal migraine that will make it distinct? It's going to be abdominal pain, unlike the classical migraine that will be in the head. So it's going to be in the abdomen and will be moderate to severe. It may last for 1 to 72 hours. But in between, the child will be healthy and well. Let me explain here. You can listen to, particularly those who are taking some medical exams. So here's a scenario. They say, okay, a child that is 5 years complaining of abdominal pain, and then after 1 hour was okay, going around playing soccer with friends or any other game, or just riding the bike. And they say, what are the possible differential diagnoses here? And what's the most possible diagnosis? So the answer is abdominal migraine. They will have the attack. Okay, they complain that they have abdominal pain. But 1 hour after, you see the child snoring again, sleeping soundly. The pain is gone. And some hours after or days, the pain is back. And it's likely going to be abdominal migraine. But it could be others. We'll go into that later on. So that means nausea and vomiting, loss of appetite, and they have pale skin. You may not find all this, but you need two of these: nausea, vomiting, loss of appetite, and pale skin, with the abdominal pain and the healthy period in between attacks. 5 attacks with each lasting 1 to 72 hours. Dull pain around the umbilicus. Yes, that is one clue to abdominal migraine. And in North America, we call it belly button. So pain around the belly button, that is around the umbilicus, might be moderate to severe. Intermittent attacks with days or months free of symptoms. Like I said, this hour, the child is complaining, severe abdominal pain, but suddenly, it's gone, and then the child is back, riding the bike around the community or the Christian, and then what is the possible diagnosis? Think about that. Now, what are the possible differential diagnoses? Why is it that we can misdiagnose abdominal migraine? It might be pyelonephritis. That is what we might be looking for: urinary tract infections, cystitis, irritable bowel syndrome, Crohn's disease, peptic ulcer disease, or gastroesophageal reflux disease. Those are possible differential diagnoses, and even more. Might be cholecystitis, particularly in somebody that is getting older now. Intestinal obstruction, or might be trauma. Might be functional dyspepsia or pelvic inflammatory disease. Might be pregnancy-related, particularly in people older. Appendicitis, or might be child abuse, and then having abdominal pain. Now, what are the possible causes of this pain? Is idiopathic, is unknown. In medicine, we are somewhere to hide when we don't know the cause. We give it another nomenclature called idiopathic. Mostly related to classic migraine. It is genetic and environmental factors in origin. Triggers and prevention and treatment of both classic migraine and abdominal migraine are similar. Complications. There will be less school days or frequent absenteeism from school. Painful, right? It is difficult to make the diagnosis, and that difficulty in diagnosis has led to too many unnecessary tests being done, because we want to rule out what will likely be responsible for this in this child. And a lot of time will be wasted, money will be wasted, besides the stress on the affected person. Wrong diagnosis with wrong medications will lead to associated side effects of those medications in the child. Other complications that may occur will be through the presentation here. So you can pause, rewind, and go up to the complications of migraine headache. They can all occur here. How can we make the diagnosis of abdominal migraine? Mostly done clinically, okay? But we will rule out gastrointestinal tract problems, renal problems, hepatic problems, vascular causes, including food poisoning. We'll rule them out first. Then we don't need to embark on any diagnosis test, because there's no definitive diagnosis test or test now. The history here should include having 5 attacks, with each attack lasting between 1 to 72 hours. And also, the history should include dull pain around the umbilicus, known as belly button, with moderate to severe pain, with 2 of the nausea and vomiting, or pale skin or loss of appetite. Let me explain here. When we are taking history of abdominal pain, I know that is abdominal migraine in a child, but I've said it could be in an adult, there must be 5 attacks that would have occurred, and each should be lasting 1 hour to 72 hours. That's one point. The second point is that there's pain in the abdomen, but the pain is at the belly button, that is at the umbilicus, and is a dull pain. Point number two. The point number three is that the pain might be moderate to severe. While point number number four is we want to see two of this. Is either we see nausea and vomiting, or we see pale skin, or we see loss of appetite. There are 4 points here, but we're looking for just 2. Once 2 are present with this, then we can clinically diagnose abdominal migraine. We will have a physical examination done, of course, general inspection of the abdomen, and we'll look for scar, we'll look for anything, because we're thinking that this might be child abuse, might be pregnancy related, and so on. You can have some tests done while ruling out other causes depending on what you are working upon as a differential diagnosis. And depending on the age of the child, you may go for human chronic gonadotrophin, microscopic culture and sensitivity, urine MCS, ultrasound, or CT, depending on what you want to rule out. And the treatment of abdominal migraine. Cognitive behavioral therapy will be helpful here. We have to keep the diary of the triggers so that we'll know how to run away from them, and then we'll be free. Once we've known the trigger or triggers, then there's no need of any advice, just run away from them. Then have enough sleep, have regular meals, let there be generous fluid, and avoid caffeine. Still on treatment, all medications for the treatment of acute classical migraines, but not with all triptans in children. So, in other words, all medications that you can use to abort and then suppress classical migraine could be used here, but when it comes to triptans, you cannot use all of them. So when it comes to triptans, which one can we use in children? We can use sumatriptan and zomitriptan. Those are the ones welcome in children that are 6 years and older. Treatment is individualized, and it is based on the presentation. Now, prevention. Prevention, they say, is cheaper than cure. That is, if the situation is even curable at all. So, first thing first, keep the diary of the triggers. Then avoid all the triggers like plague. All other medications for prevention of classical migraine could be used. But remember, when it comes to triptans, only 2 could be used. Want me to name them? I won't name them again. Go back, rewind, and go back to that page I've just told you. You can use sumatriptan or zomitriptan. I finally mentioned it, right? Now, when it comes to triggers, like I've said earlier, I'm going to repeat the same here, that nothing is fixed as per triggers. So what is a trigger in one patient might not be in the other. So don't condemn whatever you've seen here. If it's not happening around you, it's happening in someone else. Triggers in one may not be the trigger in the other person. Other triggers may have to be present before some other triggers, like food-related ones, will actually have effect. It is almost individual basis as per what can trigger the migraine. The lists here are just the common ones. Nothing is occurring in all sufferers of migraine at the same rate. No, there is no particular trigger that is going to occur in all human beings that are having migraine. No. It is fair to say then that you can't avoid all the listed triggers because not all of them will be affecting you. Your duty is to study your own trigger and triggers, and you do that by keeping a diary. The risk factors and triggers. I'll not waste your time to go through that right here. You can get that through this very presentation. Pause and rewind and go through all the risk factors and triggers already listed here. In conclusion, I've spent the last 1 hour and 20 minutes taking us through migraine headache, the CEFALY, a new device that can be helpful, medications that we can use, including the newer medications right now, the possible complications of migraine. We've gone through the risk factors and triggers. We've examined the preventive measures, and I have worked hard enough to present to you, pieces of info on abdominal migraine. With that, I believe that information brings transformation. So you'll be able to look at migraine sufferers differently from now, and will probably be able to help many of them. Help yourselves. Help someone with that headache around you. With what I've delivered here, you'll be helpful to somebody. Keep helping human race. Thank you for listening. Remember to share this. Remember to subscribe to my channel if you haven't. I appreciate it.